Bonjour tout le monde. My name is Janvier. I'm a baby doctor. This is what I tell parents because they have no clue what a neonatologist is, and some of them think it's a religion. I'm going to start praying with them. So baby doctor is easier, but it's not the kind of baby you may think about. Neonatologists take care of babies who have complex medical conditions, the majority of whom are born early, and a lot of the babies need technology to survive. For example, this baby, she's born 4 months early. She needs a respirator to breathe. She needs a central line for nutrition and hydration, and she needs a nasogastric tube to feed her milk. She's at risk of death. She's at risk of disability and complications. It's not rare in these kind of situations to ask parents to take life and death decisions for their children before they're born or after they're born. These decisions we usually take using data and statistics collected by doctors and researchers. And these are among the most difficult decisions in medicine. So in 2002, I decided to start doing my PhD on these decisions. And we chose decisions where doctors unanimously recommended palliative care. 2 of these conditions are trisomy 13 and 18. What I learned during my training is that these conditions were incompatible with life, that they were lethal. 90% of children, when they're born with these conditions, would die in their first year of life. When they survived, they had profound disabilities. I was told that their quality of life was miserable, that they couldn't communicate. In fact, the international guidelines at that point told us to not intervene, because if you intervene, you prolong death and not life. Interventions were futile, so palliative care was recommended. At that point, I met Barbara Farlow. Barbara's the mother of Annie. Annie had died. She had trisomy 13. So we gathered a group of researchers, and we asked parents. Despite these being very rare medical conditions, 300 parents reached out. What we found is not at all what the textbook says. About 160 children reached 3 months of life, and they all smiled, and we have pictures to prove it. They were all disabled. Parents said it was hard. Half the parents said their children had more pain than other kids, that they had to make significant personal and financial sacrifices, that raising a child or having a child for a short time who's disabled is harder than they thought. Yet all the parents reported that the life of their child was positive, that their child was a happy child, and that their child enriched their lives, their siblings' life, and their couple. And I'll read you a little quote by Amy, because she says it much better than me. Amy's the mother of Owen. And Amy says, "My son gave me more joy than I could have ever imagined. He has made me a better mother to my 2 girls. He taught me patience, perspective, and gratitude for everyday life. He may never have walked or talked. He did not live long, but we were a happy family. Owen loved his mobile. He loved sitting in his daddy's lap while he worked. He was not incompatible with life. He lived 102 days. He was a son. He was a brother. He was a nephew. He was compatible with our family." And sometimes a picture is worth 1,000 words. At the left, you can recognize medical pictures. These are in our textbooks and articles. They show us how to learn about the conditions. And at the right, you can see parental pictures. Since then, things have changed. We're now supposed to take decisions not based only on chromosomes, but on what happens clinically to these children. And we personalize decisions for life-limiting conditions. Some children will die in utero, some will die when they're born, and some will live long, happy lives. We then decided to look at a condition that was way more frequent, prematurity, and the goal was to improve the way we would communicate with parents and families. What we're taught in medicine is that doctors should communicate all possible outcomes and alternatives to parents or patients in adult medicine in a standardized and neutral fashion. The more information, the better. And a lot of research is about data transfer to the patient with apps, with all kinds of stuff, decision aids. At that point of my career, I believed that. So I made a parent information sheet for babies who were born preterm. Usually how it works when you're a neonatologist, you speak about the risk of death and survival, chances of survival, and then if the baby survives, the babies are categorized in categories of mild, moderate, or severe disabilities. And this is what we try to convey to parents and what we write in our articles. So this is an example of a neonatal figure. You won't be quizzed at the end. At the bottom, there's gestational age. The bars are disabilities. The red part of the bar is severe disability. The green part of the bar is mild to moderate disability. We actually speak like this. This is our lingo. This is the way we do research. And we come to believe that green outcomes are somehow good outcomes, and red outcomes should be avoided. We, in fact, take life and death decisions to avoid the red part of the bars. Then something terrible happened to me. This is me, beluga woman with sexy glasses. 19 years ago, I showed up contracting 4 months early. My cervix was supposed to do the job, was dilated. At 23 weeks at that time, 30% of babies survived. And I was confronted with medical language and the way we describe childbirth. So I was told that the reason all this crap was happening was my incompetent cervix. Incompetent cervix. Imagine if you told a man, you know, your child has anomalies because of your incompetent sperm. I'm not sure it would go well for a long time. I was then placed on bed rest, another bullshit term, because you're not resting at all, hoping that I would keep Violette inside, in Lemberg, upside down, pissing myself, with eventually a catheter, an IV, medication, and all this stuff, and really hoping she would not come out. And then Keith is my husband, another academic neonatologist, was met by another neonatologist colleague we love a lot. And she told us about the information that we knew already, because we write that stuff. And then she asked us, do you want to hold Violette while she dies, or admit her to the intensive care? And we had no idea. I told her my plan was to stay pregnant. The kind of the things you don't want to hear as a neonatologist. And you would have thought that two people who write about outcomes would be the best people to take these decisions, but not at all. I mean, the worst shit that happened is I was served my parent information sheet I had written. And I'm like, what is this crap? And sometimes medical statistics are not enough to take decisions. I had a lot of other questions that we learned that most parents have those questions. What will happen to her? I mean, can she be happy? Can she have a quality of life? Can she function in this fast-paced world? What will happen to me? How can I be the mom of a dead girl? How can I be, I thought at that point, even worse, the mom of a disabled girl? What will happen to my career? I had questions about my family. What's the impact of extreme prematurity on a family? What will happen to my couple, to my other child? We don't answer these questions in decision aids. Though this is Violette, the same baby I showed you at first. I knew how to interpret her blood gases. I knew about her settings on the respirator, but I had absolutely no idea how to be the mom of a baby on a respirator. This is her when she was born. You can see Keith's wedding ring around her wrist. In fact, wedding ring number 1, because he sent it to the laundry. So we're now at number 3. And in between the two pictures, there's 4 terrible months I won't speak to you about. You can read about it in my book. Ups and downs and terrible stuff, complicated hospitalization. And this is her at the right when she leaves 4 times the weight, 4.5 times the weight she was when she was born. It's amazing what we do in neonatology. We can quadruple the size of a patient. Thankfully, we don't do that in adult medicine. So at 1.5 years, when babies are born extremely prematurely, they come back to the neonatal follow-up clinic. They examine children. Children have a developmental test called the Bailey, where you screen for problems. And at the end, everything is put together, and children are classified into 4 categories: no disability, mild, moderate, or severe disability. So Keith and I thought Violette will ace her first exam. So this is her for the Bailey boot camp. So we were training her to get a really good mark. So she went to do everything, didn't do everything perfectly. But then we were met by a nice psychologist who said, I can't tell you the marks, but I'm very happy to tell you Violette is normal. We thought, normal? Our child is fucking amazing. But deep down, we knew that, Violette had feeding problems, she had breathing problems, she had sleeping problems, she had learning problems, a whole lot of functional problems we weren't measuring. So she was still counted as normal and a success story, which she is, because she's still amazing. So then we embarked in 2016 on the Parents' Voice project with parent partners and wonderful researchers. And our goal was to look at what was important when a baby's born extremely preterm, what is important to families, and what is hard. Our first question was, do parents agree with medical categorizations? So over a year in Canada, before parents went to follow up, we asked them for their voice. We said, look, your child will be categorized into 4 categories. Doctors have created those categories. We never asked you what you thought. We really want to know what you think. Please tell us how you would categorize your child. Parents didn't agree with our categorizations or doctors' categorizations. They tend to be more positive. So when doctors classify children as being severely disabled, only 12% of parents agree. Remember, that's the red bars. When children were categorized as normal, 83% agree. There's still 1 in 6 parents who says, hey, my child's disabled and we need help. Our second question was, do parents agree that the conditions that doctors call severe disability are actually severe? So what we did, we created vignettes of children, how they function. We told little stories. And we had the children have the severe disability that is described by doctors. And we asked parents, over 800 parents, and adults born preterm, do you think this condition is severe? And no, they didn't agree with what we call severe. They tended to be more positive. So an example, deafness for neonatologists is a severe impairment, even if it can be corrected. When we asked over 800 stakeholders, 17% agreed that deafness was a severe disability. We then asked so many questions, but one of the questions was the impact of prematurity on parents and families. Traditionally, we've measured for decades negative impacts. There's hundreds of articles about post-traumatic stress disorder, financial impacts. But parents, 85% of them describe both negative and positive transformations. The positive transformations were never reported before, such as gratitude for simple things in life, perspective of what's important and what's not, stronger relationship of who's there and to be there for them, and knowing that you're stronger than you think. Parents reported they did not want standardized, detailed, neutral information. Rather, they wanted personalized, practical information. Some parents want a lot of information and statistics. The majority of parents want the big picture. Many parents don't want to take life and death decisions. They want a recommendation. I want doctors to be balanced, to tell me the worst case, but also the best case scenario. I want to know about positive transformation, that I can do this and that they're there for me. And most importantly, I don't want diagnoses. I want information about function. And this is an overwhelming message from parents. Tell me about function and not diagnoses. And this is where the F words become essential. Dr. Peter Rosenbaum, in a 2012 study, has revolutionized the way we can speak about disabilities. We should no longer use diagnoses, but function. So I'll tell you an example, the deafness example. To tell me my child may have deafness, I'm just gonna freak out. To tell me how will she function? Does she need surgeries? Is it a cochlear implant? Is it a machine? How often I'll have to go there? Will she have friends? How will that have an impact on the family, how we communicate? Do we need to learn sign language? Will she have fun? Will she have pleasure? Will her body be fit? And what does that mean about her future? Will she fit in society? And will she be able to live independently? Now, all this is not fluff. You can measure this as doctors, and you can actually give that information to families. So what do sick babies and their family can teach us? They can teach us about gratitude, to just be able to breathe without difficulty, about perspective of what's important and what's not, and to fight for what's important. They teach us about family and connections, of who's there for you and to be there for them, not to be a backbencher for those you love. They teach us that short lives matter. They actually have value, and they make the world a better place. We can find perfection in places that often nobody can see it. Sick babies teach us the contrast between the medical system and the family perspective. So next time, or if you're ever unlucky to go and see a doctor for a critical diagnosis, remember lessons from sick babies and their families. Like, how much information do you want? Do you want a lot of detailed stats, the decision aid? Or do you want the big picture? How do you want to decide? Do I want all this stuff and decide on my own? Do I want to decide with the medical team? Or do I want a medical recommendation? What scares us the most? Pain? Death? Disability? Losing my mind? A life in the hospital? What happens to these patients? Ask your clinicians. Ask your clinician, okay, I know what's broken, you've told me, but what works? Balanced information, positives and negatives. And think about your F words. What's important for you in those F words? And what does your diagnosis change about these F words? And finally, sick babies teach us that it is possible to have our plans and dreams totally destroyed and then to rewrite our story with a new plot line. Thank you.